A complex remodeling process will occur in the cervix, which involved a timed biochemical cascade. This timed biochemical cascade makes the cervix to efface, makes the cervix to dilate at term when the woman goes into labor, in which there will be pouring of the inflammatory cells and alteration of the matrix of the cervix. Unfortunately, in some women, this will occur very early, in the early part of their pregnancy, in the mid-trimester, and they go into the abortion without their knowledge, and there is no cause, there is no pain at all. Without any pain, suddenly they will see their fetus coming out of their womb and a live fetus, because there is no pathology also. It will not affect the fetus, and this is a repetitive. So repetitive clinical condition is basically because of this disruption of the intricate mechanism which results in early cervical ripening and without any uterine activity. That is to be remembered. Totally the uterus is quotient, there is no activity. So all these women who have got a cervical incompetence or insufficiency, they end up with a loss of the fetus. The term incompetence was originally used by Shirodkar, continued to be used for many, many people. Then they thought that this incompetence word is not really the true word to be used here. So they coined it as insufficiency. That means it is not sufficient strong enough to hold on the pregnancy after the first trimester. And reason you know that why it only dilates during second trimester, by the time the decidual and chorion tissue is very close to the internal os, and fetus is also grown, and in the fetus there is a calcium deposition, bone development, weight of the fetus becomes more and more. Slowly under the weight of the fetus, it dilates without uterine contraction. That is the basic pathology which is there in this. Now, I am going to discuss the topic in the next 20 minutes, that what is its role in labor, what is its role in mid-trimester abortion, what is its cervical role in spontaneous preterm labors, because now it is a continuum. All those which were occurring as a earlier as a
sir, nimde slides can't tell us, sir.
No, batao, they will come.
Not shared.
They will come. He will say, ask him to say. So we'll find these are the reasons why we are going to find. That is the etiological factor which you should look. Now, what is the prevalence and incidence of this condition? The prevalence is not very common. It occurs once in 300 to 400 or 2000, the pregnant woman. But though it is rare, but in some it repeats so often, that's why they will feel that it is the cause. Can you share the slide? And this problem has to be thoroughly understood. And once you understand the basic pathology of this, can you go next, 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 go next. Though it is rare, but in some it repeats so often, that's why they will feel that it is the cause. Can you share the slide? Okay, and this problem has to be thoroughly understood. And once you understand the basic pathology of this, can you go next, 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 next. Arun, you go next. Both is rare, but in some it repeats so often, that's why they will feel that it is the cause. Can you share the slide? Okay, and this problem has to be thoroughly understood. And once you understand the basic pathology of
Please mute all.
Arun, you do next.
Arun, line clear illa.
Both is rare, but in some it repeats so often, that's why they will feel that it is the cause. Can you share the slide? Okay, and this problem has to be thoroughly understood.
Clear illa, sir. Clear illa. Please mute all.
Arun, please mute all the other
Arun, line clear illa.
ಇಲ್ಲ ಬೇರೆ ಮಾತಾಡ್ತಾ ಇದ್ದಾರೆ. There's a lot of disturbance.
So mute everybody.
Next.
Sir, unmute yourself. Sir, unmute ಮಾಡಿಲ್ಲ.
Mute all the others.
Yes, yes, ma'am. Yes, ma'am.
ಇಲ್ಲ ಬೇರೆ ಮಾತಾಡ್ತಾ ಇದ್ದಾರೆ. Lot of disturbance.
ಅಲ್ಲ ಸರ್ಗೂ ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿಟ್ಟಿದ್ದಾನೆ ಅರುಣ್. Sir, unmute yourself. Sir, unmute ಮಾಡಿಲ್ಲ.
Mute all the others.
Yes, ma'am.
ಇಲ್ಲ ಬೇರೆ ಮಾತಾಡ್ತಾ ಇದ್ದಾರೆ. Lot of disturbance.
ಅಲ್ಲ ಸರ್ಗೂ ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿಟ್ಟಿದ್ದಾನೆ.
Hello, can you hear me?
Yes, yes.
Yes, now we are audible.
He has unmuted me also. He has muted me also.
Yes, everybody is here.
Now,
We can see your slides also. And
Yes,
I
yes.
think Arun, you give control to sir only, so he will change the slide.
yeah. Can
Yes,
you
sir.
see the slide? on the-
Yes, ma'am. Given, ma'am.
Okay. Hello. Can you hear me? Okay, now.
Yes, yes.
Can you hear me? Can you hear me?
Yes, sir, we can.
Okay.
Yes,
Now,
everybody is here.
what are the risk factors in this condition? Somebody is
We
talking.
can see your slides also. And
Hello.
I think Arun, you give control to sir only, so
Arun,
he will
you-
change the
Mute
Yes, yes,
everybody
given,
else.
ma'am.
Yeah. Can you see the slide on the- Hello. Can you hear me?
Yes, sir.
You can hear? Can you hear me?
ಕೇಳಿಸ್ತಾ ಇದೆ sir. ಕೇಳಿಸ್ತಾ ಇದೆ.
Yes, sir. Okay. Now the risk factors in this condition are not exactly understood. However, there are good number of women who have got a congenital defect in their tissues. That is cervical tissue, there is a congenital defect. And acquired is good number of surgeries like the vigorous dilatation and curettage, operations on the cervix, and the cervical tears during very bad labor, and use of the surgeries for the cervical cancer. All these will lead on to the development of an insufficiency in them. Now, if that is the reason why they will develop a cervical incompetence, but you cannot diagnose a cervical incompetence in the primigravida. So this is only possible when a woman has come with a history, that there should be an history of a painless, causeless, the mid-trimester abortion in which you are going to identify this problem. Now, can we identify this problem in any individual without the any of the history? The most important is history. Unless you take a very proper history in this, and history should be is the most prime, and even nowadays we are talking of history directed surgeries, sonography directed surgeries. Earlier we used to say that it is therapeutic emergency, but here now in this condition, one thing what I would like to stress is that you should be able to identify the short cervix. Normally the length of the cervix is 4.5 to 5 centimeter. In any woman during the pregnancy from the second trimester onwards, if you are able to see that who are those women who are having a short cervix, you can definitely recognize this condition and you can do some preventive, may not be for continuing the pregnancy up to term, at least to such time that the fetus is viable. And what are the ways of doing that? Now, broadly, diagnosis of this condition can be done. One is by physical examination. Another is by sonographic examination. These are the two ways of diagnosing this condition. And the physical examination is that it is unfortunate, many of our gynecologists, they never do a pelvic examination to a pregnant woman at all. But if you make a habit of doing a pelvic examination after 22 to 24 weeks of pregnancy, putting a speculum and looking for the cervix, the length of the cervix can be easily assessed, either by visual or by palpating the cervix. And if you are able to identify the cervix in the anterior fornix by palpating it, that if it is more than 4 to 5 centimeter, the chances of having insufficiency are not there. And the physical examination, that examination of the feel of the cervix, what is called as digital examination of the cervix, is also very important. And this digital examination will tell you what is the feel of the cervix. that cervix which is going for insufficiency will be very, very soft. If you find a soft cervix, if you find a cervix which is short, then you can diagnose clinically the cervical insufficiency. But nevertheless, clinical diagnosis is not so easy. That's why today the standard examination is only by doing a sonography, the diagnosis. So based on the obstetric history of recurrent second trimester abortion, and nowadays we are also adding the spontaneous preterm labor syndrome also as a requisite for cervical incompetence. That means a woman who has got a cervical incompetence, she will end up with mid-trimester abortion, or she may end up with early preterm labor syndrome. So digital examination is very subjective. So that's why you cannot take it as a guarantee. I feel what I have got a length, it may not be a same length for somebody else. So that's why the most important is the ultrasound examination of the cervix. And in the ultrasound examination of the cervix, to begin with, everybody started with a transabdominal sonography. Now today, you believe me, transabdominal sonography has no role in the diagnosis of cervical insufficiency. If at all you want to do, you must do only transvaginal ultrasound. Now the reason why I'm telling is that transabdominal sonography, the probe is very, very far away, that it will not identify the actual length of the cervix. And number two, the actual measurement is also not enough. And when you want to do a transabdominal, you need a partially or full bladder. There the length of the cervix is going to alter. Today the standard, all the RCTs which are suggesting that you must do only a transvaginal the examination. And when you are doing a the examination, there are 5 tips that when you are using the probe, you have to use the probe on an empty bladder. You have to put the probe in the anterior fornix of the cervix, and you should see that 75% of the screen of your sonography occupies the cervix only. Then you have to identify the cervical length right from the internal os to the external os. And with the caliper, you measure the cervix. And anytime when the cervix is less than 25 mm, that is the critical sign that you are ending with a cervical insufficiency. Any length between 2.5 centimeter or 25 mm to 5 mm is a normal cervix. So this is a very clinical way of identifying the cervix. Number one, you should go to the length. Number two, there are different shapes of the cervix which can be identified in vaginal sonography. Normally, the cervix looks like a T-shaped cervix. That means it is the only one single length is seen in the cervical canal. But once the insufficiency is there, once the cervix starts dilating, the funneling will start. And when the funneling occurs, it will go into a Y shape. And if the funneling is extensive, it will go into V shape. When the cervix still more dilates, it will become almost U shape. So these are the types of the cervix we identify in the vaginal sonography, that is T shape, Y shape, V shape, and U shape. And by that, you can identify that you are dealing with the cervix. You can see here the representation by a diagrammatic presentation that a cervix which is a T, and you identify that it is one in the, that the T is the closed one, that is the internal os, and this is the external os, and change is the Y, U, and V. Now, these identification can also be done in sonography. Look at the sonography finding, the funneling, and funneling is very important, and that is the beginning of that. Once the cervix start funneling, the presenting part, whether it is head or it is limb buds, whole thing, the membrane will protrude into the cervical canal. And when it is protruding into the cervical canal, then it will further protrude it, and you will find that there is a total, and this is the cervix, what you can see, that here is the head, and that is the internal os, this is the external os, where you can see a very long cervix, almost 4 to 5 centimeters the cervix, which you can see. Now you see how the funneling has started. And once the funneling has started, the liquor will come in between the presenting part, and slowly it starts dilating. And you can see the dilatation of the cervix very closely. And when you are looking for this in the insufficiency, you can identify sonographically. That's why today the sonographic diagnosis of cervical insufficiency is most recommended one. So we must learn how to do sonographically, that to vaginal sonographically, to identify the cervix. Many times we refer all our antenatal cases to the radiologist. And most of the radiologists, they do a transabdominal, they will not do a transvaginal because they are not very comfortable with that. That's why as an obstetrician, we must learn ourselves to do a transvaginal examination and follow these rules of without a bladder, without the urine, empty bladder, keeping the probe properly and measuring right from internal os to the external os. You will be able to diagnose in most of the cases. And once you diagnose, it is very important that you have to follow up the cases. And you may need almost every fortnight or every week follow-up. And in the follow-up, if you are doing, sometimes you may have to do vaginal sonography every third or fourth day. And at a critical time, when you feel really the cervix length has reduced less than 2 centimeter to 2.5 centimeter, you must go for surgery because these surgical techniques have gone almost 100 years. And they are so standardized that benefit to the patient is definitely there. So that's why in most of the cases, we go for the surgical approach. And in the surgical approach, what we are going to do is that once we identify that there is an incompetence, then we must plan the management. And in the management, there is a medical management, there is a surgical management. Now, what is there in the medical management? In the medical management, bed rest is also advised. But there are many RCTs where bed rest is not so useful, and you can go for restricted movement. These women must be told not to move too much, and in some centers they will put them in the head low position for a long time. Any number of the days the patient is put in the head low position so that the pressure of the fetus part or fetal weight is not put on the cervical canal and cervix will not dilate. That is one of the methods which can be tried. However, today the surgery has become and surgery is so useful where you can do a transvaginal, transabdominal, you can definitely do it. And another point which I would like to stress upon is the progestational therapy. Progesterone, as all of you know, is a drug which keeps the uterus quiescent and which keeps the cervix also silent. So you can start on a progesterone, almost the 17-alpha medroxyprogesterone once in a week or once in 15 days, depending upon the severity of the problem. Intramuscular progesterone is also advised. And the other earlier things, pessaries and other things have been tried, but they are not so good. So that's why in the management, these are the medical management. And with this brief introduction of the problem and understanding of the basic pathology and how to diagnose, and definitely cervical insufficiency cannot be diagnosed clinically, but there are two ways. One that you can, in the intraoral period, you can use the Hagar dilator. And if a 8 number Hagar dilator is easily inserted inside, that it is a case. And this catheter filled up with 2 ml of fluid can also be. But these are not the very good methods. Only method and tested method is a close follow-up of all these cases, those cases where there is a previous history of the preterm labor, spontaneous preterm labor, previous history of midterm, the abortion, the second trimester abortion. They all should be closely followed from 20 weeks onwards. And in fact, you should start right from 14 to 16 weeks. If you are able to follow these cases every 14 to 16 weeks, in 2 to 3 weeks, and in a duration of every 2, you will be able to identify this condition, and you can go for a decision of putting a cervix, the cervical encirclas. My friend, Dr. Patil Jaiprakash Patil will tell you what are the different, the indicated, the cervical encirclas, what is the recent classification for that, what are the methods which can be used. And in the next part, time is running out for me. Now already I have covered half an hour. I thank you very much for listening to me and help and knowing that the basic aspects of the cervical insufficiency. Today we must use only the word insufficiency, not the incompetence. Incompetence is a misnomer. Insufficiency is the right term. I think now all the literature suggests that we must use only insufficiency as a word. And all these surgeries are really a very good surgeries, which will give a very good result. Now, with this, I would like to conclude that the historically a disease which has been made women to suffer for a long time, unhappiness in their family, not having a child. Now these surgeries which have been introduced by the Dr. Shirodkar and McDonald, and now with the people like Jay Prakash, laparoscopic surgery, interval surgery, they all have made that this clinical condition, once upon a time when it was thought that it is untreatable, now it is a treatable, and all these women can be given a benefit of having a child. Thank you very much.
Thank you, sir. Thank you for briefing about the cervix. Now I move upon to our second speaker, Arun. Arun? Arun?
I think Dr. Jaiprakash Patil has got his first slide as his CV.
Yes.
Yeah.
Now moving to the second speaker, Dr. Jaiprakash Patil. He's a laparoscopic and a pelvic surgeon, director, Bettur Advanced 3D Laparoscopic Center, Raichur. He's a chairperson of endoscopic committee, KSOGA, senior consultant and teaching faculty, RDT Hospital, Battapalli, operating faculty in several state and national conferences. His area of interest is endometriosis and fertility enhancing surgeries. So today he will be speaking about surgical procedures for cervical insufficiency. JP?
Namaskaram,
Huh.
Namaste everyone. I'll just share my screen. First of all, I would like to thank MG sir for this opportunity. He had called me and told me that you should speak on cervical insufficiency. One moment. Yeah. Is my screen visible?
Yes, yes.
Yes, sir. Thank you very much. So, sir has covered almost everything I knew he is going to cover because he is an academician par excellence. So, I have stuck to very practical aspects of the cervical insufficiency surgeries. Okay, so I'm not going to tell you the academic, background of the whole thing. So, I'll going to be very, very practical as far as the surgical aspect is concerned. So, it's a very beautiful quote. It is usually impossible to know when you have prevented an accident. Like, it is as simple as wearing a helmet or putting a seat belt when you drive a car and putting a stitch. Sometimes, I always feel that the cervical cerclage is both underused and overused procedure. Now, we see some, gynecologists putting cerclage left and right for almost every pregnancy, even if she had a first trimester abortion, which is obviously not because of cervical insufficiency, but she undergoes a procedure. But having said that, as MG sir said, many scans which are done by radiologists not being detected in time, funneling is not detected. So you will underuse it and then end up with a preterm delivery or sometimes even an abortion much before the viability. So the scope of this talk, as I already said, I'll be covering only what types of cerclages, what are the varieties we are going to use, when is the timing, and obviously more emphasis will be on McDonald's, Shirodkar, and laparoscopic cerclages. Okay, in historically, if you go, there are a lot of varieties which are because the quest, as MG sir rightly said, is been there for centuries to have a good procedure for cervical insufficiency. Till Dr. Shirodkar, then came the McDonald's, and then came Benson Durfee, and there were many others which were tried in between. So, sir has already mentioned, we have history-based, ultrasound-based, and the third one is, usually we call it as an emergency cerclage, but Americans like to use it as a therapeutic cerclage, whatever terminology you would like to use. Okay. Now, timing, it is very simple. If it is a prophylactic, that is history-based, that is, she has had 2 or more abortions, or it is a proven cervical insufficiency, usually we prefer to do after NT scan. Okay. Now, UST-based, when the cervical length is less than 2.5 centimeter or there is a funneling, then you would like to put a cerclage. Now therapeutic, obviously, you don't have a timing for that. Whenever you feel that, okay, there is bulging membranes are seen and you want to salvage the pregnancy, so you put it SOS. This is about the timing. Now, these varieties, what I have mentioned, lash and lens, months ischemic cerclage, external wrapping, somebody used a graft, they shaved the cervix and put a skin graft, thinking that is good. So many things have been tried. Okay, so many things have been tried to make this insufficiency, to find a proper therapy for insufficiency. And somebody even tried the electrocautery scarification of cervix, hoping that scar and fibrosis will hold the pregnancy till term. Now, of the clinical significance, I have already told Shirodkar's and its whatever modifications, McDonald's and its whatever modifications, and the Benson-Durfee, which is abdominal or laparoscopic. Okay, I'll be discussing one by one. Now, the McDonald's, which is most popular, I would rather say, uses, nowadays we are using silk, and you don't have to open the A pouch, that is the anterior pouch, and you put the cerclage all around the cervix as high as possible. Okay, because you have a bladder reflection. Posteriorly, you are fine, absolutely fine, because the pouch of Douglas gives you a very large margin of safety, whereas anteriorly you have bladder reflection. So you have to take care. As you see the rugosities, you just stop and then take a bite. Now, worm stitch, I want to just put this slide just to mention it. Now, I don't think anybody is using worm stitch, but this was designed basically for emergency cerclages. Now, you put 2 stitches which will oppose the cervix anteroposteriorly and also transversely. Okay, so basically this is to hold on the products of conception as a last desperate measure. But now we have better surgeries available, both laparoscopically and vaginally. I don't think now wombs has any role to play, but I don't know if somebody is practicing still. Now this is 1 minute. This I have downloaded from the web. This is a McDonald's stitch. Now, most of us are taught by our seniors and the teachers that use a sponge holder. I beg to differ. I would prefer to use a good pair of Alice forceps. Instead of one, I use 2 Alice, because sponge holder, sometimes if the cervix is soft, usually it gets crushed. Okay, that is the one tip I want to give. Use 2 Alice forceps. Just bring the cervix. Now hold the anterior speculum and look for the rugosities of the cervix. Identify where the cervix ends and then the bladder reflection starts, and put a stitch all around and then put a tie. Okay, so he's putting 2 in this model, he's putting 2 low, but usually we get about 2.5 centimeters of cervix if it is done as a prophylactic measure. Okay, if the cervix is effaced, I'm really not very happy to put McDonald's stitch, because once the effacement starts, somehow the bladder reflection comes down so fast, and then you don't get effective length anteriorly. So as an emergency procedure, personally, I don't prefer McDonald's. I'll come to the video of Shirodkar where we get almost 3.5 centimeters of cervical length when we put this even as an emergency procedure. So this is just to show, take 3 or 4 stitches all around the cervix as high as possible and put a knot posteriorly. Now, obviously, okay. Now, usually, if it is done as a prophylactic procedure, that is history based, you can tighten as much as you like. Okay, because cervix is a fibrous organ in a early pregnancy. Whereas as you advance, or if it is as an emergency procedure, cervix become very fast. So you have to just tighten as much as just you see a indentation onto the cervix and stop. Okay, that is the rough guide I can give. Now, if you go through cerclage levels, are you seeing this picture?
Yes.
Hello?
Yes,
Yes,
yes.
yes. We are
Are
able
you
to
seeing
yes.
this picture?
Yeah, we are
Yeah,
seeing.
yeah, we are able to see your all the pictures.
Can you hear me?
Yes,
sir.
All are very attentive,
Hello?
Jay. Go ahead.
now we are able to see the picture. Continue.
Sir, can you hear me?
Yes,
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 yes.
yes. ಕೇಳಿಸ್ತಾ ಇದೆ.
No, we are able to see.
I can't hear
We are
anything.
able
I
to
don't know
see.
if I'm.
We are
Can
able to
somebody
see the
type whether you can hear me?
Yes, yes.
Okay. I will continue. Sorry, somehow I thought I'm not. Okay, fine. Okay. So if you see this picture, now the McDonald's is the lowest part where you get about 2 to 2.5 centimeters of cervical length after cerclage. Whereas if you put a Shirodkar, that is the removable Shirodkar where you don't open the posterior pouch, you get almost 2.5 to 3 centimeters of cerclage. Now, Benson-Durfee, which is transabdominal laparoscopy cerclage, you get almost 3.5 to 4 centimeter. Now, having said that, where we do Shirodkar by opening the pouch of Douglas, we almost get 3.5 to 4 centimeters of cervical length. I'll be demonstrating this in my next video. Now, this is the video. This is available in YouTube also. You can see this is done as an therapeutic or as an emergency cerclage. Now you can see bulging membranes. If the bulging membranes come up to the external os, what I usually do is I put an inflated Foley's bulb and push them down. Okay. Then once we tighten it, then after that I remove. Now in this case, the bulging was just up to the internal os, so I did not push it with a Foley bulb. Now here, once there is an emergency cerclage, I usually prefer to open the pouch of Douglas. So if you open the pouch of Douglas, what it makes is you have an access above the uterosacral level. Now, if you know uterosacral, at the just above the uterosacral level is your internal os. Okay. Now that is why it is very important to get a full length of cervix, that is about 3.5 to 4 centimeter, by opening the pouch of Douglas. Now, if you are doing as a prophylactic measure, probably you don't need to open the pouch of Douglas. Now, many people tell me, okay, you don't have to open the pouch of Douglas. Yes, I do realize. But if you open the pouch of Douglas, you can be very sure that you are reached at the level of internal os. And I have got very good results personally. That is why I prefer to open the pouch of Douglas. Now you see here, we have opened the pouch of Douglas, push the bladder up. I don't have to open the anterior pouch. Remember this. I don't have to open the anterior pouch. Previously, we used to use the Shirodkar needles, where it is kind of aneurysm needle. Here, what I usually do is now W22 thread with the Marcelin tape comes with a good thick needle. So I palpated the uterosacral attachment. I just go about half a centimeter to 1 centimeter above the uterosacral and just go below upwards, go at the level. You can see the length of cervix I am getting. Okay. The length of cervix I get is excellent. Actually, in this case, there was more bleeding than usual. Usually we don't see so much of bleeding unless we have a kind of trauma to the one of the uterine vessels. Again, you come above downwards and just put a tie. Okay. Anyone who is doing vaginal hysterectomy, anyone who is comfortable opening the pouch of Douglas and pushing the bladder up can do this procedure. It doesn't require great skill. Whereas doing laparoscopic cerclage in a gravid uterus requires lot of skills. Remember this. Okay. So personally, I usually do laparoscopy cerclage as an interval procedure And in gravid uteri, I always prefer to do a modified Shirodkar. Okay. Now just tie this. Now the question comes, how is the mode of delivery? Now, most of these women will end up with the elective section. Okay. If somebody is very eager to have a vaginal delivery, you have to take her under IV anesthesia, that is TIVA, and then open the pouch of Douglas and cut this tape. Okay. Again, same thing. If the patient goes for PPROM, or if it is a non-viable pregnancy, or if there is IUD, you don't want to do a C-section or hysterectomy. What is the solution? Take her under IV anesthesia, do a pouch of, open the posterior colpotomy, open the pouch of Douglas and cut this tape. And then you can allow her for vaginal delivery. Now, if you do an elective C-section at a term, you can leave this tape in situ and she can have more pregnancies without needing to have a cerclage again. Now, if you see there, the length of cervix we have got both anteriorly and posteriorly is amazing. Usually we have demonstrated up to 3.5 to 4 centimeter. Okay. Now this is a laparoscopic cerclage. As I said, I usually combine, I usually do interval cerclages by laparoscopically. My justification is, usually I want to do a hysteroscopy, number one. Number two, want to assess if there is any septum or a subseptum, or if there is any other cause. You may find adhesions or something in intra-abdominally. So I want to assess everything as a fertility assessment and then go for cerclage. Now you see, this technique is devised by Dr. Hafiz Rahman himself. We do a broad ligament window on both sides at a avascular space. I'll tell you why it helps to make a avascular window. It will allow you to visualize the level of cerclage placement exactly at the level of uterine artery insertion. Okay. So otherwise you'll be struggling to visualize whether I have entered at a proper place or whether I have not entered at the proper place. This dilemma will always be there. So we make 2 broad ligament windows sufficient enough to visualize the passage of the needle. Okay. This is how we do. Now this procedure can also be done in a gravid state. See, I have friends like Sandesh Kade, Anil Magdum. They all do laparoscopy. They never do Shirodkar. They are more comfortable laparoscopically. I, being both vaginal surgeon and laparoscopy, I have taken the middle path. Okay. Now, this is how we do. Previously, I used to straighten the needle. This is one of the older videos. Now I don't do. I take direct bites. You pass the needle posterior-anteriorly from one side or antero-posteriorly from one side, whatever which is your preference. Now, where do we enter? 2 anatomical landmarks. Number one is, I said, just below the uterosacral attachment. You can see posteriorly. And anteriorly, a space between the uterine artery and a cervical substance. Okay. Now, some people say you have to go through the substance of the cervix. I say not really required. I don't usually care. I come at a avascular space between the uterine artery and the cervical tissue. As you can see here, I have come through that and then I go antero-posteriorly. Same space, you can see uterine vessels laterally, and just medial to that, enter the space there and come posteriorly and put a stitch. This whole video is there in YouTube. If somebody, because I have edited because of the time constraints. This muslin tape is now available with 2 or 3 companies. Previously, only Johnson & Johnson was making. Now, I prefer to put the not always posteriorly, because in case you want to remove the tape, like for example, this is an interval cerclage. If the baby turns out to be anencephaly at 14 weeks. So, it is easier to do colpotomy and cut the stitch if it is posterior. If it is anterior, sometimes you may or may not be able to palpate the stitch and then able to cut it. So if you have a knot, it is a lot easier. Now, in a special situations, okay, this is a unicornate uterus, okay. The cavity as it is very less. This patient had an abortion at around 14 weeks or so. And then on 3D vaginal scan, my colleague Dr. Rajagiri Reddy told me, this is how I do nowadays. I don't straighten the needle. Just go below upwards and then come above downwards and then put a stitch posteriorly. Now, I just want to tell my very little experience of, of these special cases. In Mullerian anomalies, whenever we have put a cerclage and previously whatever gestational age she had an abortion, after putting the cerclage, we have gained about 4 to 6 weeks, which is a game changer. Imagine she had a abortion at 24, 26 weeks. We have taken her to 34 weeks. Okay, especially in Mullerian anomalies like this, bicornate uteri, unicornate uteri, or sometimes I combine with, if it is a complete septum, usually they will have cervical insufficiency. T-shaped uteri, they are known to have cervical insufficiency. All these people, I prefer to do a therapeutic, like septal resection or whatever, followed by prophylactic cerclage. This has been my practice, and we have got very good results because of this. Dr. Sanjana's classmate, my senior Dr. Ganga Patil is big fan of interval cerclages for Mullerian anomalies, because we have got very good results with our patients. So what is the general post-operative care? Nothing much. You tell them to avoid coitus for 2 to 4 weeks, basically to prevent the infection. Okay, you don't want. And then after that, if they are very keen, I usually tell them to use condoms. Now, we have to rule out asymptomatic bacteriuria. This is the most common culprit as far as the PPROM is concerned. Okay. Otherwise, just 2 or 3 doses of antibiotics, which is enough. And I usually prefer to give 3 to 7 days of progesterones. After that, they don't need to take any other medications. This is a general post-operative care, nothing really special about it. So I would like to thank KSOGA family, not only for this opportunity, for my term as a endoscopy chairperson for last 2 years. Thank you, and thank you very much. What I have missed in this talk is laparoscopy cerclage during gravid uteri. I thought of downloading it from Sandesh's Sandesh's YouTube channel, but I could not. So those who are interested can watch Sandesh Kade for gravid uteri cerclage in YouTube. Thank you. Any questions? I am open to that. Thank you.
Yeah. Now, question and answer session will be moderated by Dr. Rajeshri Paladi, madam. I see many questions in the chat box, so madam will be moderating the session.
Can I add little more before question?
Yes, sir.
Dr. Patil, regarding tocolysis and antibiotics, I think one thing is we have to cover with antibiotic, because our operation theaters are not so clean.
Yeah.
We may induce an infection. Infection is the worst thing to happen in this case.
Yes, sir. Yes, sir. Absolutely. Absolutely.
And tocolysis also has been used for a very long time. For all those patients, when we used to do the McDonald or Sirotcar, for 24 hours, we used to keep them under tocolysis with IV. Then we used to change with intramuscular injection, then oral about a week or 10 days. Nowadays, many people are not believing in tocolysis, and even RCTs have not shown the positive result with tocolysis. But antibiotic and progesterone, I firmly believe that those two are very, very essential.
Yes, sir. Actually, usually I do give progestins oral, because you don't want to put vaginal progestins, because the fear of introducing an infection. So either I use dihydrogesterone or sustained release of the natural progesterones. That is the choice. And antibiotics, yes, sir, absolutely fine, because there will be inherent. That is why I always get a urine culture done in these women. Most of the time, that is the culprit.
Okay. Good evening, everybody, and hearty congratulations to Dr. M.G. Remet sir for always enlightening us with basics of the topics and also the most relevant clinic topics. And sir, there are so many congratulatory notes for you in this group of chat box that there are only 2 questions and most of them are congratulatory notes. Thank you very much, sir, for clearly describing the aspects of the cervix and the cervical length, and also stressing upon the point that antibiotics have a major role to try to curtail. There is one question by Dr. Ravikanti: role of routine screening for cervical length in asymptomatic patient or in primigravida.
Yes, can I answer?
Yes, sir.
So now many of the RCTs, they suggest that if you want to prevent preterm labor, today you know preterm labor is the most obstetric complex problem we are facing. And if you want to avoid a preterm labor, you must classify them whether they are general population or high risk population. If there is a high risk population, serial sonography is a must, at least every 2 weeks. Even in general population, if you make it a habit of measuring the cervix at every time when you are doing a sonography, because nowadays, you know, the number of sonographies are done equal to the number of months of pregnancy. And if you don't do also, patients are requesting every month they ask you for a ultrasound examination. And if you are able to see the cervix every month, and if you are able to measure the cervix transvaginally, I think you can detect a good number of cases. As Jaiprakash has told, if you miss the train, you will miss everything. I think that is the best way of doing a transvaginal sonography at every visit in the every 1 month. That means 4 weeks. I think you can prevent many the mid-trimester abortion and many the spontaneous, the preterm labors. That is my opinion.
Sir, I have one question for you. That is there any role to do the cervical swab testing for culture sensitivity to identify the presence of any infections? One thing. And is there any role of prophylactic antibiotics in patients who have had a history of previous abortion to start from the 4th month of pregnancy, apart from doing the assessment of the cervical length? Does it help us to prevent, because we have heard in some persons that they practice giving antibiotics prophylactically monthly to prevent cervical incompetence, because that is one of the important reasons, as just now Dr. Jaiprakash mentioned, that urine infection and cervical infections are the important factors for cervical incompetence.
Yeah, there are nearly 8 to 10 RCTs which
sir.
suggest that a cervical swab is the best. That if you are planning to do a surgery, better you take a cervical swab and rule out the culprit. And you know, in the initiation of the effacement and dilating of the cervix, inflammatory response is the problem. And this inflammatory response can be there in a woman who has got already existing cervical infection, like she has got a cervicitis. And you know, good number of pregnant women, if you put a speculum, how bad their cervix, sometimes you feel why nothing is happening with such a bad cervix. I think always it is good to have a swab and good to give a antibiotic which is sensitive, number 1. And number 2, the second question is prophylactic antibiotics, none of the RCTs suggest. And there is no need for a prophylactic antibiotic. We are giving in all circulars because we are interfering. And iatrogenic induced infection should not occur. That's why antibiotic is given. Otherwise, none of the RCTs are suggesting that you should give an antibiotic to prevent the preterm labor or prevent the mid-trimester abortion. And they are not going to help also.
Thank you so much, sir, for clarifying these doubts. Now coming to Jaiprakash, sir, excellent demonstration of your videos and procedures and very simple and clear talks. And I heartily congratulate you for taking up this topic. And as we see, we have more than 90 logins today, sir, which doesn't happen often in our
Yes, yes.
it's a very good response and interest, because the topics are so relevant, so practical, so clinically significant, that you have chosen such beautiful topic, because every obstetrician would like to know what to do more about the cervical problems and issues that we have. I would also like to welcome Dr. Kasturi Donimat ma'am for this webinar, who is although on a different time zone, but she has made it a point to log in into this program. And Dr. Nagraj sir has conveyed that he is in Bangalore attending some personal issues, so he could not log in, because he is unable to log in from the place that he is right now. But we acknowledge his presence for all the programs and webinars that we have. Thank you very much, sir, for your blessings. Coming to Dr. Jaiprakash sir, you have a lot of questions to face. And we
I
are
think he answered most of his queries.
Rajesh,
the chat box
I'm
only.
answering these queries on chat box.
Yeah,
Yes,
yeah,
Rajesh,
he is
can
answering
I-
the chat box.
Yes,
Can I
but
add
for the
something,
benefit
Rajesh?
of the audience, can you please answer them point-wise? That one of the question is that at what dilatation should you not do emergency circulage by Dr. Bhagyashree?
Ma'am, I just answered that question on chat box. See, first of all, any circulage, emergency circulage, one golden rule is patient should not have contractions. Patient should not have signs of chorioamnionitis. Patient should not have a leak. Okay, that is a peril. See, we are talking about pure cervical insufficiency, so it has to be put for only pure cervical insufficiency. If she is getting contractions, if she has tachycardia, if she has any signs of infection, if she has leak, no, she doesn't fit in. Now it comes. Now effacement is the issue, not the dilatation. We are worried about the effacement. Okay. Now the moment, even sir said the U shape. Now once it is U shape, the whole BO bag of membranes has come out. Okay. Now all we do is we just put a the Foley bulb inflated. Sometimes I use a uterine sound. In a urologists use these 18 or 20, 24 number catheters. I put the uterine sound into the Foley catheter and then inflate it and push the whole bag of membrane, and I have applied the cerclage vaginally with excellent results. Even at the advanced stage of 24, 26, we have applied. That is the beauty of vaginal procedure. Whereas in laparoscopically, it is very difficult. You know, my friends are doing, some people are doing laparoscopic cerclage, hats off to them, but I feel very comfortable vaginally. So there is no, sir.
Can I add something, Patil?
Sir, please.
Regarding worm stitch.
Sir.
See, worm stitch we have used many. I can remember I have done almost 20 to 25 worm stitch.
Yes, sir.
The point is that, as rightly told by Patil, there should not be uterine contractions. Any stitch which you put, if you put it against the uterine contraction, it will go to tear. And 3 centimeter dilatation is the criteria, wherein if it is more than 3 centimeter, if you put a stitch also, it may not be very much helpful. But now recent RCTs which are showing that if you want to have success in early preterm labor, what I mean is between 28 to 32 weeks, if you have done a scan, serial scan, and if you have found that the cervix has dilated to some extent, there you can use this worm stitch. And this worm stitch will help you to carry on the pregnancy for another 1 week or 2 weeks. That 1 week and 2 weeks makes a lot of difference in the lung maturity. That a 30 weeks pregnancy can be taken up to 32 weeks. Along with that tocolysis, antibiotic, I think there it will help. And worm stitch is the best stitch for everybody to learn. If you can't learn a chirurgical stitch in the beginning, as you have seen right now, Jaiprakash, how complicated it is. And even McDonald's stitch is also very complicated. I request everyone to do a worm stitch. If you have got a patient who has come in preterm labor, you put a worm stitch. And you know how it is simple. You can start from the posterior and go to the anterior. That is at the 4 o'clock. Then you go to the 2 o'clock. Then you come to the 11 o'clock. Then you come to the 7 o'clock and tie on the posterior. It's a very easy stitch. And you push the membrane, as rightly told by Jaiprakash, put a Foley's catheter, push the membrane back, put the stitch, and put her on a headlock position for a long time, tender position. I saw one of our greatest teacher, obstetrician, Dr. Indumati madam. I saw her putting one patient in her nursing home for 2.5 months in the headlock position. The patient was there for 2.5 months in the headlock position, and she pulled up the pregnancy up to 34 weeks, and she did a cesarean at 34 weeks, and that patient went happily with a child in her hand. I think nothing should be left. If there is an opportunity, you put a stitch. Even if you don't put a stitch also, that will go into a preterm labor and it will end up. I think everybody should make this habit of doing a serial sonography, either in a patient who has got a previous history of preterm labor, or in a patient where you are finding with your digital examination the cervix is less, or with your transvaginal sonography the cervix is less than 2.5. Every effort should be made, because these surgical techniques have come as a very big way to solve this problem.
Okay. Thank you very much, sir, for that clarification. At what dilatation not to do the emergency cerclage was one question by Dr. Bhagyashree.
Yeah, I think I have answered to that. There is no criteria that don't do even after this. Even if it is 5 centimeter also, you put the worm stitch. There is no difficulty in putting the worm stitch. Push the bag of membrane back and do it, and make the uterus the quotient. And you must put properly the tocolysis. If the uterus starts contracting, then it will progress, and tocolysis should be given.
Sir, Jaiprakash, sir, thank you, sir, for that information. When we are using the McDonald's stitch, is it relevant that we take the stitch posteriorly and not anteriorly? And what would be the choice of the suture material?
No, I personally use number 4 Mersilk silk.
Okay.
I have reservation about using a Prolene, but I have met many people who have got excellent result with using Prolene also.
Yes,
That's
sir.
non-obstructive. My logic is, yeah, I think it was you, ma'am. You told, I think I had a discussion with you, Bharati ma'am,
Yes, yes.
that you are happy with Prolene, but that's fine, a personal choice. I personally use number 4 silk. One company, I don't know if it is Suture India, has come up with a suture material specially designed for cerclages. So that is what I use. And question is, I think anterior, not in anterior.
Yes.
No, usually you don't want to put a knot anteriorly, even if it is a McDonald's, because you have a bladder.
Yes.
Whereas in posteriorly you have a pouch of Douglas which has good amount of length. You don't injure rectum there. So that is the only thing, because you have a bladder so proximity in proximity. That is why I don't want to put a knot anteriorly. That's all.
JP, one more advantage of the knot posteriorly is removing it when she comes in
Yes,
labor
yes,
is very
yes,
easy when you do it.
Yes, ma'am.
Very easy.
Yes, ma'am. Yes, ma'am.
Anterior
Yes,
is difficult, but
Correct.
posterior it's easy to remove.
Correct, ma'am. Agreed.
Another point is whether there is any role for routine cerclage in twin pregnancy or in IVF conception.
No.
In the recent era of the pregnancies out of assisted reproduction, most of the infertility specialists, they are using prophylactic cervical encerclage. From the time they cross 12 to 14 weeks, they are all putting a cerclage. And all these, even twin pregnancy, even triplets, cervical, the encerclage will help a lot. I think it is a better method of doing it. Number one, I want to go back to previous. In the original Shirodkar, the material what he has used, he has used chromate catgut.
Yes.
At that time, only chromic catgut was the available one. And then they came a modification of the material. That was called as modified Shirodkar technique. See, in Shirodkar techniques, 2 modifications came. One is the change in the material from the chromic catgut to black silk. And for a good number of years, 40 to 50 years, every obstetrician has used a black silk. Now from black silk, we are going for Mersilin tape and the modified Shirodkar. And even in Shirodkar, original Shirodkar, he suggests you to go up to internal as. But in modified Shirodkar, what they say is There is no need to go up to internal os and go for dissection. For example, you saw the dissection of Jaiprakash. I have never dissected the posterior pouch. We have always opened the anterior one.
Anterior.
The reason why we have opened anterior is we want the bladder to go away. Push the bladder away and don't injure the bladder. Posterior we have never approached and we have never done also. And personally, I feel there is no need to open the posterior and have so much of bleeding and all that. And anterior opening is also very simple. Just push the bladder little up and put the, and not necessarily that you should put at internal os. The pathology is not at the internal os. The pathology is below the internal os. And the cervical length, if it has reduced to 2.5, it is the midpoint of the cervix where the elastic and fibromuscular tissue is weak. If you tighten that, that is more than enough. I think surgery procedure also becomes simple. That is what is my feeling.
Thank you, sir. Thank you so much for the valuable input. There's another share by Dr. Shilpa, which has been put in the chat box as a reference from the ultrasound Journal of Ultrasound Obstetrics and Gynae, that anterior cervical angle is a new biophysical ultrasound marker for prediction of spontaneous preterm birth.
Yes, good. I forgot to mention that there is a society which is called as the only for this society for the ultrasound evaluation by vaginal. And that society is suggesting that you must see that angle. That angle is very, very important. That's why I was telling you, all those who do transabdominal, they miss that angle. And by missing the angle, 1 to 1.5 centimeter of the cervix can be misdiagnosed. And when you misdiagnose a cervix of 1 to 1.5, definitely your therapy will not be correct. Thanks for reminding me that. I think I will got it. I will tell you what is that called as the uterine activity, the society. That is the society which is suggested.
Thank you for the new learning points. Shilpa, if you're there, would you like to contribute something towards this discussion?
Thank you, ma'am. Good evening, sir. Hiramad, sir. So just one point. Usually nowadays we are seeing more and more of this cervical insufficiencies which are associated with polycystic ovaries and obesity. So it is mostly to do with the cervical function rather than the length of the cervix, probably. So, so there is something called as elastography in the newer ultrasound machines which are utilized, which will tell us about the muscular content and the fibrous content in the cervix. But then again, like whatever we do, finally it gets difficult because the interpretations and the studies which we have till now doesn't say anything concretely as to when we need to intervene. But because of more and more IVF pregnancies and more PCOS obesity, I think the incidence of cervical insufficiency has increased. I don't know, this is what we feel as infertility specialists, but amongst common gynecologists, I would like to have everybody's view on this.
Very valuable inputs here.
Commonly, I think in the general population, we are not seeing a drastic change in the cervical insufficiencies. But there's one thing I would say, there's something wrong with the collagen tissue, because what earlier days we have this resistance to dilatation in many of our primigravidas. I would ask Dr. M.G. Hiramad to opine on this, because nowadays, even if they are term, post-term, the effacement and the dilatation of the cervix is not as what we used to see in earlier days. I really don't know. Is this something to do with the collagen tissue of the cervix, which is transforming?
Yeah. Dr. Bharati, in the beginning of my presentation, I have told about the composition of the cervix.
Yes, sir.
And this tissue, what is it, is a combination of elastic and the other tissues like proteolytic and cellular portion. There is a disulfide band. And unless the disulfide band is broken, cervix will never dilate, cervix will never efface. And those are the cases where you find, in some cases you induce labor, but they never respond. Yes, because sir, you are failing to divide this disulfide bond. And this disulfide bond will only divide provided there is an evidence of infection. And that has been found that all those patients who are going to preterm labor, they have done biopsies of the cervix. what they have found in the cervix biopsy is that they have found that there is a stromal inflammatory infiltration of the inflammatory cells. If the inflammatory cells are infiltrated into the cervix, then only the cervix will dilate. Otherwise, it will not dilate. And prostaglandins have also a role. Those women who have got a prostaglandins, the imbalance, they will end up with dilatation. And those are the things which have been identified.
Thank you, sir.
Thank you, sir. Sir, I would like to add one input, if time permits, that everything said and done, in spite of all the monitoring, all the serial monitoring and measurement of the cervical length, but cervix is one tissue which behaves very, very differently and very strangely. That recently I had a patient, a student of mine, conceived with twin pregnancy. She was taking the antenatal care in nearby metro, that is Hyderabad. So ultrasound scan was done, everything was normal, 3.5 centimeters of the cervix. She came to get the registration done and the booking after 15 days of the ultrasound in Gulbarga. And when I did just a routine transvaginal ultrasound to know everything is fine, she was already 3 to 4 centimeters dilated with bulging cervix, bulging membrane. So these are the kind of scenarios we come across, that although we vouch for the length of the cervix, for the width of the internal laws, but still surprises pop up, and we really have to be very, very diligent that a stitch in time really saves 9. And this is one sentence which can sincerely apply in precious pregnancies, in multiple gestations, in IVF pregnancies, that maybe we have to weigh the risk and benefit ratio. So it was a wonderful, wonderful.
I
just want to add here, whenever you are taking the history indicated ultrasound, one should always do this first trimester ultrasound and rule out any anomalies. And also you should screen for any aneuploidy.
Yes.
Otherwise, you put the suture, and as Jaiprakash told, that later on we land up in some problems. So investigation before putting cerclage are also very mandatory. And I think rule out some people, even they do amniocentesis if they feel that there are contractions or there is any sludge, as you were talking of the cervical swab. They even do pre-cerclage amniocentesis. Of course, we don't do those invasive procedures, but I think there are some of the studies which indicate they do pre-cerclage amniocentesis. And of course, the antibiotic coverage they do. So these things. And what about the CBC and CRP? How many of us we do before cerclage?
It has to be done.
No.
It has to be done. Yes.
I would like to add one point regarding Silpa's question.
Yeah.
All these infertility people, they want their pregnancy to continue and give them a live child. Now, in that, what is like you just I will give you a simile that a car driver, when he goes to on the road, see, there are people, they will only cross when there is a green light. There are people who will cross when there is yellow also. The red and green, there is yellow. All these infertility people are yellow people. So they don't want to lose the pregnancy at any cost. We will put one stitch.
And put lot of progesterones.
Yes, all routes of progesterones.
All routes of progesterone.
All routes of progesterone, and close the door. And in the beginning only I have told you.
I think Mahesh is not there here.
Well, I think probiotics given in these women who come with persistent infections play a good role in preventing this cervical insufficiency.
Yes.
I think.
See, cervix is nobody can close it, nobody can dilate it. When you want to dilate, it will never dilate. When you want to close also, it will never close, because it is a unique organ. Cervix is a
very true, sir. The patients whom we have put encerclage thinking she'll have preterm will not develop labor pains even after 41 weeks. We have seen that, sir. Yes. Thank you. Thank you so much for this interesting.
Yes, so much exhaustive discussion.
Informative.
For a long time, I was longing to have this discussion on cervical.
Very nice topic, sir.
Yes, sir.
Really, congratulations
and useful,
to you.
very useful.
Because my all postgraduates are enjoying. They have all joined.
Nice.
There was a 30 marks question in DNB exam. Only the question was cervix. That's it. Nothing else. Cervix.
And the best part of cervical insufficiency is a very small surgery, rewarding, and good earning. Very good earning.
Good earning. Yes, sir.
And
doing
those
an
who will
adequate-
put the stitch,
Sir,
the patient will go for
CGHS
delivery.
cervical
definitely.
surgery, cervical insufficiency surgery charges are 3,000 rupees.